and it's on the replay. I am Lolita Harlem. I am the CEO of the nonprofit organization My Natural Me, but also the executive director of this particular program, which is our Dementia Caregiver Support Program. And it is exactly as it sounds. It is providing support for caregivers and bringing connections and people and resources together because, as I always say, the problem is bigger than all of us combined. So, the more that we can come together and have information and resources, the better for everyone. So, I welcome you, and I want to introduce my co host who just somehow amazingly appears right when I need her. So, Sydney of Wrath, I am so glad that you were able to join me this evening. And I'm going to go ahead and turn it over to you to do a bit of an introduction of yourself and the organization that you support.
Sure. So thanks so much for having me. I'm glad I was able to make it on. My name's Sydney Plinkett. I'm a social worker with the RAFT program. See the logos behind me here. So RAFT, we serve the Northern Virginia area. We are focused on providing support to older adults living with dementia and their caregivers. So our services are totally free, helping folks better manage the disease process, understand the disease process, plan for the future, and we also provide respite care. As I said, we are in Northern Virginia, but we do consultations for folks regardless of where they live. And I know sometimes we have folks on this call that are all over the place. So please feel free to reach out to us, even if you're not in Northern Virginia. And I'm happy to put our information in the chat.
Wonderful, wonderful. Thank you so much, Sydney. So, for those of you who are joining, I always say if you want to leave your camera off, as a caregiver can be kind of sensitive. Sometimes you're just trying to listen to get information, but feel free to drop questions, drop your contact information if you want one of us to connect you with someone. We are also connected to a number of medical professionals. My This program is actually working in partnership with a local family practice. We also just had a family practice doctor join our team. And then we also have resources with hospice nurses and all of that. So if you don't get something specifically today, but you have questions, definitely reach out. And yeah, and like I said, just drop it in there. I'll pause throughout to just give anyone a moment if they want to come off camera or ask questions or talk. And with that said, I'm going to go into a little bit about what we'll be talking about today. So, with these, we use this as a support group, but we try to have specific topics that have kind of surfaced over the past month or so that people might be having questions around. And one of the things that we commonly get, and we have actually talked about this before, I was looking back at some of our previous ones, and we have had some conversations around palliative and hospice, but it's just so common, right? Because as the disease progresses, you at times may need to start looking into some of these type of options, and they can be really scary to think about, to talk about. So part of the purpose of tonight is to kind of take some of the fear out of it. And you know the old saying, knowledge is power. And I know as a person who is directing this program and also living with someone who is, support part of a caregiving team of someone who's living with Alzheimer's dementia. um, I've learned that there are so many things that I was really afraid of because I didn't know the full picture. And so the more you can know, the less just anxiety it can take out of it. So tonight we're going to talk about a little bit about palliative and hospice care. And before I dive into that, I do want to give a moment. If anyone wants to just share kind of what their experience, maybe just say hello, ask a question. I'll give just a minute or so if anyone wants to pop on and say anything. And I'll just check the chat. All right. I don't see anything anything burning right now, so we will jump into so I do have a document, because I know when Sydney when you and I were talking about this, we both said we have information, we provide these resources, but it's one of those things that if you're not living and breathing this specific thing, sometimes it can be you need that refresher. So I did get some information from NIA that has like just a plethora of information on these topics. And so I'm going to share my screen allegedly. You know, I always get me and technology are not always friends, but let's see. Okay, so yeah, screen two and share sound. Okay. All right. So I want to make sure you are seeing the screen that says myths about palliative care.
Yep, we can
Yep,
see
we
it.
can see it. Yay! So the first thing we'll do is just again, I'm just going to kind of go through this. And as I mentioned, if you have questions, you can feel free to just unmute yourself, come off camera, or drop it in the chat. Sydney will also be kind of checking the chat. So definitely, if you have any questions, you can put them there. So, myths about palliative and hospice care. So we'll start with palliative care. As you see there, it talks about what it is, and its focuses on improving quality of life for people with serious illnesses and their care partners. Now, I will share talking about myths. I thought originally that palliative care was just for people living with dementia or dementia related illness. I didn't realize that it's something that people use for a lot of different types of illnesses. So, when we talk about the myths here, as you see, it says, "When I begin palliative care, I can no longer receive treatment for my disease." So that's one of the myths that is kind of like an end of life type of thing, right? But the fact is, palliative care can be provided along with curative treatment. So, Sydney, I'm going to pause there. Do you want to add any more depth behind what it says there on that particular one?
Yeah, sure. So I think one of the things I think of palliative care to sort of help it make sense for me, because it is sometimes a little bit confusing. There's types of care for illnesses that is curative, right? It's trying to cure whatever the disease is. And then there's types of care that's more focused on comfort, symptom management, and looking at the whole person. And that's palliative care. So it doesn't mean you don't have the curative care as well, right? So it could be, with cancer treatment, you have your chemo, which is more the curative care. Palliative might be spiritual support on top of all of that, support groups for folks that are going through this, support for your family as well. So you can have them in conjunction.
Wonderful. That is very helpful. Very helpful. Thank you. All right. And then we'll move to the second myth, in fact. So the second myth says, I can no longer see my primary doctor when I start palliative care. And the fact is that palliative care teams work with primary doctors. So again, that goes right along with what you were saying before. Again, people tend to think that this is just kind of like an end all be all, that you can't work with it. Sydney, do you know where that myth came from? Why people feel that way? Is that something that kind of was just out there in the sphere of things?
I don't know. I know that there are some different types of health groups where it's like you could only work with us. And I think people might think that palliative is that same level of restriction, when really it's a very, very broad term. When we talk about palliative care, it's really encompassing so many different types of things. And I think people have a very specific idea of what that is, and it's just much broader than that.
Yeah, thank you for sharing that. Awesome. And again, knowledge is power. So those myths, even though it's only two that's listed here, they can really be limiting, right? So if you believe these things, then certainly you can see how someone may hesitate on reaching out for this type of care.
Hmm.
So then when we go over to hospice, now again, this this is tricky, right? Because I think most people associate hospice with very end of life, very limiting. But first of all, the definition itself says focuses on the care, comfort, and quality of life of a person with a serious illness who is approaching the end of life. So that part is in there. But what I've learned, and we'll go through the myths and facts, and then we'll kind of dive in a little deeper because I've learned that it's kind of not quite what you actually may immediately think of when you see that approaching end of life. So let's
Mhm.
kind of dive in a little bit. So the myth is in hospice care, I can't receive any treatments. And then the fact is, people may receive medications to help manage symptoms, but not treatments to help cure their illness. So, Sydney, what's your added part on this?
Yeah. So, this I love this diagram. But visually, the way I think about palliative care and hospice care and sort of the relationship between the two is palliative is the umbrella, and hospice is actually a form of palliative care, right? So that's the form that comes at the end of life. So just like all of palliative care. You're still receiving treatments, but when you enter hospice, it's not treatment that is curative or trying to cure the disease. Um, but it can still be some other types of treatment, medications to help manage symptoms and things like that, pain.
Yeah, yeah, that is very helpful. And then the second myth that it lists here is hospice care is only provided in a hospital or hospice facility. And the fact is, it can be provided at home, in a hospital or nursing home, or in a separate hospice center. So I think that can be comforting because if you do have a loved one that maybe this is starting to come, as a possible consideration, people may
Mm-hmm.
hesitate if they think, well, I want to be with my loved one. I want them home. So
Mm-hmm.
this is comforting to know that it can be done. You can get hospice at home.
Mm-hmm.
Any other feedback on that?
I I think that one's an interesting myth because it's really common. It's a common myth, but I volunteered for hospice actually for a bit of time, and nobody was in a facility. They were all at home. I think that's actually the majority of people that are in hospice. But I think it's a really common thing. I know one of my friends, her mother passed away a few years ago, and as she was passing, she kept asking, when am I going to go? When am I going to go to hospice? Right? Like, am I going to be sent away to some place? And that, never happened. She was able to stay at home and have people just come in and provide that support.
Yeah, yeah. I know one of the women in our support group shared that they just brought in hospice for her mom.
Hmm.
And what's interesting, and I try to sometimes your reaction happens before you can actually think about it. So
Hmm.
because those myths still kind of exist in my brain, when she said it, I was like, "Oh, like, I'm sorry." I went to say, "I'm sorry."
Hmm.
And her reaction was actually like, "I feel really good about this." Her
Yeah.
mom is in the stage where there's nothing, like, there's not any reversing of anything
Hmm.
happening. It's not going to There's nothing they can do to, like, improve her condition.
Hmm.
So, she's like, "It could be months, it could be years, but it's just at the point where we're not trying to, like, rehabilitate or, like,
Hmm.
build up anything. We're just trying to make sure that she gets what she needs as she's in this stage." So I
Hmm.
thought that was kind of a nice way to look at it because people do think of it as a very, like, hospice, and then maybe a couple of days or weeks later, that's it. Any
Hmm.
additional thoughts on that in your experience?
Yeah, I think oftentimes hospice is utilized too late. I know like my grandfather was put on hospice and he passed away within a week. Um, but there were so many incredible services, and for the folks that I know, nobody regrets getting hospice too soon. It Right? Like their illness and whatever the prognosis is going to be what it is, but hospice comes with so many resources for families, and you can be on hospice for a long time. When I was volunteering, the folks that I met with, my, volunteer clients, I met with them for years, that they were on hospice. So, it can be a little bit more closer to the end, but that's often because somebody's referring them too late. So I think as service providers, we, at least in my team, we try to refer people to hospice as soon as possible, because it just comes with so many benefits for the families. It looks like we have something in the chat as well. Someone shared, my mom was put on hospice care because she deteriorated in the last 6 months. It was a horrible experience. My mom was given so many medications that she just had to be admitted to a psych hospital to get her detox and her medication corrected because the nurse did not know what medications caused problems with other medications. Oh my goodness, that sounds like a very, very terrible experience with hospice, and I'm so sorry that you experienced that. I guess
Yeah,
it really does depend, I think, on the provider um of the hospice, of course, as well, of kind of what that
yeah,
experience is going to look like.
yeah. And I wanna hold that space for our person who contributed that comment. We typically don't say names,
Hmm.
but I like I said, I want to hold that space because there are sometimes there's ugly stories out there and painful ones. And you bring up a great topic. And Sydney, you let me know if you have connections in this area. I'm finding more and more people talking about the over medication of seniors in general, like not even
Hmm.
just simply that are dealing with, or specifically that are dealing with dementia related
Hmm.
illnesses, but overall. And I know there's a couple of pharmacists out there who have actually created organizations to fight this. Um, I know I've seen it in different workshops that I've gone to where there's been some really bad stories of loved ones, especially if they are in a cognitive impaired state, where
Hmm.
it can be difficult to recognize that something is wrong.
Hmm.
I have been kind of trained, I'll say, to refer people to pharmacists because pharmacists typically are very much about the actual medication, and they seem to be the ones that are caring about interactions and things like that.
Hmm.
That's been my experience through the different workshops and trainings I've gone to. But Sydney, what do you have to say about this? This is a growing problem that we're seeing.
It definitely is. I mean, for the folks that I know we work with, they're often on many, many different types of medications. And I think, I'm not against medications in general. I think that they can be really helpful and have their place. But especially with dementia, when we see folks who medication is being put in place as like a control mechanism for challenging behaviors. And again, I think there's a time and the place for that for folks that have like that extreme agitation, and we really do need some sort of pharmaceutical approach. But focusing on those non-pharmaceutical approaches, I think is really important and not getting as much highlight by physicians. And I think, unfortunately, from facilities as well. It's a lot easier to give someone medication than it is to take a little bit more time and use different communication skills. But when folks are on so many different types of medications, they start interfering with each other and causing a lot of issues. Yeah. Just
Yeah, I
looking
know.
at the chat here, it sounds
I,
like there wasn't even an issue with agitation in this case, which I'm very sorry to hear.
yeah, wow. And okay, so we have another comment. Again, we'll share. Someone stated that their dad was in hospice and it was a godsend. It came into his home and was so comforting and helpful to me as a caregiver, as well as to my dad. I learned so much during his care and throughout the grief period. Couldn't have done it without hospice. So that is
Mhm.
refreshing. That is refreshing to hear that it was a positive experience. And I think to those here and that may be watching this later, um, just overall, I'm a big on being your own advocate.
Mhm.
So when you have these negative experiences, definitely reach out to us, reach out to Sydney. We can help just get resources to you. And even if it's no more than just kind of sharing that these negative experiences happen, that we can
Mhm.
bring awareness to it. Because we certainly love when things work well, but our heart does ache for those times when they don't go well. And that is the reality. Sometimes they don't go well.
Mhm.
Um, so I appreciate both of you sharing that experience. And our first person brought up something that I do, again, this wasn't part of what we were going to talk about, but I love it. Um, Regarding diagnosis. Now, if you've been following me in our support groups and videos, I have been big on getting a diagnosis. But I have to say, as I've been working with a lot more people, sometimes I wonder, is it as do we want to worry so much about the diagnosis? Our person here, our guest just shared that there was a misdiagnosis, right? It was diagnosed with Alzheimer's, then with Lewy body, which are two very different types of dementia. So, Sydney, are you still, because I know we both were big on diagnosis. Are you still, what's your thoughts on that?
So I do think the diagnosis is still helpful. I see what you're saying, but from the my perspective, we see folks sometimes who families they see their loved one having memory trouble. They jump right to it's probably dementia, right? Because mom's older. That's probably what it is. And they know dementia is not curable, so then they don't do anything. Not that they don't provide care, right? But they don't go check out with the doctor. And there are things that are curable that can cause those memory troubles. So I think getting a diagnosis is helpful. We don't always know what type of dementia.
Right.
That's the harder part about the diagnosis. Doctors are good at deciding if it is dementia or not, but not always what type. And there's new tests out there for Alzheimer's, which is making it a little bit easier for folks to recognize the plaques and the tangles in the brain. And I think the different dementias have some distinctions in the beginning, but towards the end, not as much always, right? They start to look
Yeah.
very similar in the end. So um, knowing what type of dementia I would say is less important than just knowing for sure, is this dementia or not, or something that we can do something about.
Yeah, yeah, because we've often, which I got this from you all, and I use it all the time, the example about cancer. And so if you replace it and you think of dementia, you can
Mm-hmm.
replace it as cancer, right?
Yeah.
When you even if you tell someone, oh, I was diagnosed with cancer, typically the next question is going to be what type of cancer, because you're going to treat breast cancer, for example, very differently than you would colon cancer.
Mm-hmm.
I mean, they may have the same, things that they do, but it's different treatments, and a lot of things are different. So that's why we have definitely been encouraging to try to get those diagnoses.
Mm-hmm.
Um, like you said, especially in the beginning, because it can make a difference in just some of the things that you do. But I will say, even without a diagnosis, I think kind of like what you were saying, Sydney, like just knowing it's dementia, like it's a
Mm-hmm.
dementia related. So if you at least get that, you rule out all those other things. And one day we'll have to have you actually do your full presentation for one of
Okay.
these, because Sydney goes really into just the different types and a lot of good solid information. So in the beginning, though, I think it is definitely key, because there's so many things that mimic dementia that I wasn't
Mm-hmm.
aware of until I started working with Raft, from UTIs to a bad medicine interaction. I mean, so many things, right?
Mhm. Yeah, yeah. I mean, one of the common ones, normal pressure hydrocephalus, which is like water on the brain. It's an abnormal buildup of spinal fluid that can cause challenges. I was just actually talking with a family today. Father's having a lot of trouble, and they think it actually might be dehydration.
Wow.
He's not been drinking enough water. He was like, I don't really like water. So they're trying to figure out how can we keep him hydrated, especially on these really hot days, so it's not causing these cognitive challenges.
Yeah, yeah. And as we kind of think about our palliative and hospice care, these are typically things that people start considering when their loved one is in the more advanced stages.
Hmm.
And so, a couple of things that I wanted to also share. I know many people are familiar with Tipa Snow and the different ones, the experts out there that have like lived, breathed, sleep all this information, right? And one of the things that I learned from that in a couple of courses I took there, and even just seeing it in real life, no matter the stage that a person is in, no matter what stage your loved one is in, even if you're at these stages where you're starting to think about palliative and hospice care, my biggest takeaway is don't feel like you're giving up. Because
Mhm.
even in what we may call final stages, still have the same behavior that you've been having all along.
Mhm.
So some of the evidence shows, and I got to work in a nursing home briefly, and it was actually beautiful to see it because even what they consider their advanced stage uh, patients, there were certain things that when I would do, you could see a bit of a reaction. Like I would touch their hand and soft and get very close and very eye level, and you could see them lift their head up a bit, right? So I think that's another thing that I wanted to share as we're talking about this particular topic, where people might be thinking of these things. Don't feel like you have to give up on the same tools you've been using during this whole illness. Um, anything you want to add to that?
Yeah, I love that you brought that up, that it really isn't giving up. And I think one of the things we talked about in the hospice that I volunteered with is we had a billion hour training to be a volunteer, and they they talked a lot about how we talk about dying, but it really is, it's the last stage of life, and focusing on it is still life, and whether, even though it's going to look different, you can still have meaning and joy and have a good quality of life even in that last stage. And I think that's a lot of what hospice is about, making sure people even at this last stage, do have that really good quality of life. And it's helping to ensure that for them and also that support for you as a caregiver, which is really vital. And then there's extra support for you after as well.
Yeah, and I know like I said, when I was working in that nursing home, hospice was even coming in the nursing home,
Hmm.
working with some of the patients there. And so I thought that was really interesting. And to be honest, some of the ones they were working with, they didn't seem at all like end of life. Like they were really, still spunky and all of that. So, I think it's sharing that just to say, like, as you're going through making these type of decisions and you're looking into, um, I guess, like I said, the biggest thing I'm trying to encourage is try not to. All this is heavy, right? It can be heavy. It's emotional. It's our loved ones, but try not to create a finality around it and try to look at it just as another resource, another tool in this whole process in this journey.
Hmm. Yeah, I think, when we talk with families about hospice, it can be really emotional and feeling like I don't want my loved one to qualify for hospice. That's a scary thing, because medically, for hospice to be covered by insurance, you do have to have someone saying about 6 months of life. However, doctors are wrong all the time, and something can look like 6 months of life, and you have someone who qualifies for hospice, and then might be like someone who I volunteered with, or I think it was just Jimmy Carter, who was on hospice for what, like 2 or 3 years.
Mhm.
So it really doesn't necessarily mean that they just have to qualify that way. Um, but it's not necessarily the end. It's just
Yeah.
more support. It's just another tool in your toolbox.
Yeah. Yeah. And let's kind of spend some time talking about, because of course, like I said, this is always the resources for the caregiver.
Hmm.
So let's talk about just some additional ways that caregivers can just navigate this journey. Again, Sydney, you have for years worked with caregivers. So, what are
Hmm.
some things that you've seen work as far as just navigating, keeping your mental faculties and yourself in check? Like, what are some tips that you would give?
It's a big question.
I know. That's why I gave it to you.
Yeah. So we actually do a whole training on caregiver self-care, although I like to frame it as caregiver resilience because oftentimes I think self-care, we think like, okay, go do this extra thing for yourself. But it can't be that way, right? Oftentimes we see caregivers who are putting all of their own stuff off to care for their loved one, and their needs and your doctor's appointments and your, exercise and eating well all has to come also first. And that's easier
Yeah.
said than done, obviously. So planning for the future can be really helpful. Figuring out, who is your support network and trying to feel comfortable asking for help. I know we often don't do that. A lot of times there's people in our lives who want to help, but they don't really know what to do. So asking for specific help from people can be really helpful, right? It
Yeah.
can it can
Yeah.
be it gives people purpose when they want to support you, but they don't know how. So definitely doing that, focusing, I think, on educating yourself about the disease process. I know most people here are caring for someone with dementia, but whatever the illness might be, the more we know about it, the better, especially with a disease that might make your loved ones say things that are really mean to you, or have a personality that's very different than the person that you once loved and had this relationship with. So knowing kind of where those things are coming from just makes you stronger, and better able to manage, and answer questions with folks, when people are having false beliefs or seeing things that aren't necessarily there. You having all those tools of how to respond can be really helpful. And
Yeah. I
I
love
think,
that.
yeah, it's not a sprint, right? It's a marathon with this disease. It can be slow and hard and messy, but then there's also really joyful moments and funny moments too. So I think like embracing those is also really important. I'm sure we all have examples of times that things are just fun. I just had a client today. He tried to give me a job at his foundation that he's going to start, and I'm going to get a brand new Bentley if I work for him. And we were chatting it up about this great new job opportunity. Um, just
I
think
love
just
that.
finding that joy is really, really important.
I love it. I will add, we always talk about support system, and we tend to think about support systems as our immediate friends and family. But I will share a quick experience. So, as I mentioned, I'm also a caregiver, and my loved one has been doing really, pretty good, all things considered. And a few weeks ago, she wandered outside, and we hadn't seen anything like this I mean, it's probably been about 4 years now. We
Hmm.
hadn't seen anything like that. So I was like, I'm glad, I don't have that particular issue.
Hmm.
And somehow I was downstairs, she got past my husband, she got past my stepdad, and the neighbor basically was able to kind of bring her back to the house.
Hmm.
So I immediately went just into action, like, getting her, and I got her a shower. But when I stepped away, I broke down. It felt so like almost not a finale, but like a just, oh no, we're here. And now what
Hmm.
does this mean? And what do I need to do? And so my coworkers, we have like a group text for like work or if we're running late. It was
Hmm.
probably like 9 o'clock at night. And I sent the group text and I was just like, this just happened and I can't get myself together. and the outpouring of love, and then they shared, like, some of them have dealt with that with parents that,
Mhm.
had it, and then I even posted in our Facebook support group, and people were like, "I went through this, and you can try getting this, and this worked for me." So I share that to say, yes, sometimes we want, our siblings or our best friends or people
Mhm.
that we expect should be there for us, but reach out to people who maybe you wouldn't necessarily think of as a support person, and you'd be surprised the comfort that you can get and tips and resources and all of that.
Mhm. That's a really great, kind of example there. I think there are people that are gonna show up in ways they don't expect them to. And kind of on the flip side of that, I think one thing that's also important to remember as a caregiver, and I know at my family, we've gone through this, there are some people that are not gonna show up, right? And they're the people that we think should. And sometimes that can compound some of the stress because we're feeling frustrated and feeling like this person should be doing this. And while a lot of times those frustrations are valid, it's not always helpful. And I think just accepting sometimes like people are going to be who they are, right? Whether we we like that or not. And
Yeah,
sometimes the advice that we get from folks isn't always helpful. When you're the caregiver who's in it day in and day out, you have a pretty good idea of what's going on. And then we call it in work kind of the daughter from California who comes in and suddenly has lots of good ideas.
oh my
And that can
goodness,
be
yes.
really, really frustrating, right?
Yeah,
But that relative from California isn't necessarily trying to be frustrating. They're trying to help. They just don't know our realities the same way that we do. So I think like not trying not to take some of that criticism or unhelpful advice too seriously, right? We're the ones who know our situations best, and people help in ways that aren't always helpful.
yeah.
Just to be
And
real.
right, right. And you had mentioned earlier too about asking specific. So I like to kind of spell it out because
Hmm.
sometimes, again, what we think is specific is
Hmm.
still broad to people, especially if they don't get it. So what I have encouraged people is to get it very, very small bites. So it might look like, can you pick up bread, eggs, and milk from the store for me, right?
Hmm.
Or can you come and sit with my loved one for an hour because I have to go do XYZ? Like
Hmm.
very specific tasks, because sometimes if you're like, like we said, well, I need help, or can you help me, can you help me with whatever?
Hmm.
They're still just, it's still too broad.
Right.
So I have found very successful when you are able to give that specific thing, even when you're sharing with family, right? Like maybe it's, can you make sure to pay these bills
Hmm.
for our loved one, right? Or can you pick up the medicine from the pharmacy? Like very specific small tasks, and they're small, but they can make the difference in maybe you getting an extra few minutes
Hmm.
of just self time, right?
Yeah. Yeah, absolutely. And I think that's the thing. People want to help often, so they just don't know what to do. And even like spending time with your loved one sometimes can be challenging because we know socialization is so important for folks. But often when someone gets a diagnosis of dementia and their normal hobbies that they used to do are kind of fading away and their normal way of communicating has sort of changed, their friends will often pull away. So I think anything we can do to help those folks of, he would love if you visited, talk to him about this, or show him this photo album, or this is something you can do with him now that your relationship is looking a little bit different. People often need that type of support, and they want to be there. They just don't always know how anymore.
Yeah. I recently took my mom to get a mani pedi, and
Hmm.
it was sundowning time. So if
Hmm.
you're on this call, or if you're watching this, you probably know what sundowning, but, I don't even know, like, I know what it is, but I don't know how, like, I don't know if they've determined why it happens yet. I didn't think so.
I
But
don't think so.
basically, sundowning is kind of as it sounds, like, in the evening as it goes into night, dementia symptoms, people living with dementia tend to get, exaggerated. They can become, that's sometimes often where, like, hallucinations can come in, so it's called sundowning. And
Mhm.
so I took her to get a mani-pedi during that time period, but it was the best time for me to go. So, but what I did was I told them there what was the state, like what she was dealing with.
Mhm.
And when I tell you, I ended up like videoing and taking pictures because they took so much care. And it was a bit of a language barrier as well, but they were
Mhm.
just so gentle. Like, if you've ever gotten your nails done and you got to put it in if you got like the gel nails, you got to put it in the thing and then you got to take them out and, sundowning, dementia, like you might as well be giving them like an algebra problem because it was just like, what?
Yeah.
But she was so gentle with putting
Oh.
it in and taking it out. So I share that too. Sometimes we hold back because we think we might be protecting their dignity, or maybe we feel like we don't want people to see them this way. But
Mhm.
especially now, I mean, I could go on a whole tangent about how widespread dementia is. I mean, they're calling it the dementia tsunami and all these scary terms. It is it is, I mean, astronomical numbers of how many people are living with dementia and expected to be diagnosed with dementia within the next 5 years. So it's
Mhm.
not as taboo as it once was. People are
Yeah.
like, somebody knows someone either in their family or in their friend's family. So it's becoming more common.
Yeah,
So that could be
absolutely.
another way. Yeah, that could be another kind of support for you. Don't hold back. If you need to go grocery shopping or you still want to kind of maybe like I said, do something, an outing or something, people are going to understand. People are going to
Mhm.
get it.
Yeah.
Yeah.
There's actually a whole movement, Dementia Friends. It started out of the UK, and there's a lot of them around the country now with this idea of how do we make our communities dementia friendly, right?
Mm,
So for folks that, they're not in this field necessarily, they're manicurists and hairdressers and bus drivers to understand a little bit more of what this looks like and how to support folks. So we don't need people just staying in their homes all the time. They can go out into the world and have a little bit of extra patience and care and kindness from those folks.
I love that. I love
Yeah.
it. I am going to pause a moment because I do, so that same NIA website, they have a little video. It's 2 minutes. And I do want to show that. So here we go, technology again. So let's just see if I can share my screen. And this is just another good one for us. So let me see here. Okay, we're going to hit share and we're going to hit screen two. And I'm going to hit share and let's hit.
Palliative care and hospice
Elevate
care.
your.
What is the difference? Palliative care and hospice care are two types of care for people with a serious illness. But what's the difference between the two types of care? And how do you know which one is right for you or your loved one? Let's start with palliative care. Palliative care is specialized medical care for anyone living with a serious illness, such as cancer or dementia. Patients in palliative care can receive medical care for their symptoms, along with treatment that is meant to slow or stop their illness. The main goal is to improve a person's quality of life. The palliative care team works to prevent or ease suffering and help patients and their families make difficult healthcare decisions. Palliative care can be delivered in a hospital, nursing home, palliative care facility, or at your home. Hospice care is a type of care for people with serious illnesses who cannot or choose not to continue their treatment to cure or control their illness. While palliative care may occur at any time during a serious illness, hospice care typically occurs when a person has 6 months or less to live. Hospice care is similar to palliative care in that it aims to help improve a person's quality of life. It also helps family members cope with their loved one's illness and death. Depending on symptoms and end-of-life care wishes, hospice care may include services such as emotional support and spiritual support for the person and their family. Hospice care could also include relief of symptoms and pain and help with advanced care planning. Depending on the situation, it can be provided in the hospital, at home, or in a facility such as a nursing home. To learn more about palliative care and hospice care, visit www.nih.gov/palliative-hospice. Palliative care and hospice care.
Stop share. There we go. Uh-oh. I thought I turned it. There we go. All right. So I just wanted to share that again, even though we definitely talked in great detail about it. I always like to defer to those ones that can give the added extra professional wording. So again, this NIA has a lot of really good information. While we both do a lot of work in this field, especially Sydney with Raft and her counterparts. We do a lot of work in this field, but we also always encourage you to go to your doctors, to your the ones who are doing the scientific research and things like that. That's a part of the service we provide, right? Sydney is making sure you can get connected to those resources.
Exactly. Yeah. And I just want to talk a little bit more about what exactly hospice offers. And the video shared a little bit, but just some of the specifics, because I think folks don't always know, like, what does it actually mean? And of course, every hospice provider is different, but generally it's medication management to make sure your loved one's not experiencing any pain towards the end of life. They can bring in spiritual support for you and your loved one. Generally, they offer support groups, bereavement support groups for folks. Oftentimes, they're very specific. So it could be a spouse support group, child support group, depending on the cause of death as well. They also will really prepare you for that very end. And I know those are hard conversations and it can be scary, but I'm someone who, like, the more you know, the better I feel. And they really will talk you through, okay, if my loved one is passing at home, what is that actually going to look like, right? Like, what can I expect those last days to look like in terms of eating and drinking when that stops happening? And do I force them to, like, what does that look like? And they can kind of talk you through that. Breathing will change. They'll talk you through, what it's going to sound like and how it might sound a little bit scary towards the end, and prepare you for that. And then who do we call, right? The loved one has passed. What does that next step look like? And they will come out. I know I was with my grandmother when my grandfather passed. It was just the two of us, and hospice came out 2 a.m. And they were there with us during that time, which was really, really comforting to have. So they're there in the fun moments of, like, bringing in music therapy and making sure folks are having enriching moments throughout that time, but also in the harder ones where you do need that support and you need someone who knows what to do when we're in situations that don't feel as comfortable.
Wow, thank you. That is really good. And we do have, I know a hospice nurse who will be joining as far as being able to provide that as a resource. And then we have another nurse who has been a dementia nurse for 20 years that also will be able to just add again. And we'll be putting that on our website soon, so that you can reach out directly to them if you have. Maybe you're like, is it time for this? Is it not? It might be unsure of knowing where you are
Yeah.
in that process. So we always like to refer you to those medical professionals, doctors, neurologists, those
Mhm.
nurses. That's what they do.
Yeah.
So you can quote them. Don't quote me, quote them. But no, it's just again about making sure you have what you need as you
Hmm.
go through this journey.
Yeah.
Yeah. So we'll give some time now. Does anyone have any questions, any thoughts, anything they want to share before we wrap up? Give a moment.
And feel free
And
to
then,
unmute also.
yeah,
And sometimes typing away can be hard.
yeah. And as we wrap up, I know sometimes these topics can be a little heavy, and sometimes people they feel like they're ready to have these conversations and then it's heavy, you know. So I do want to just encourage here live, if you've watched this and you've gotten to this point, to just take that moment and, pause for yourself and kind of reset and whatever you may call it spiritual, whatever that thing is for you. If it's praying, if it's journaling, if it's candles, whatever your thing is, especially once you've gotten to this point in this session, like I said, like either live or playback, just so that you can just kind of ground yourself.
Hmm.
And exercise. These are just some things that can be really good to kind of get you centered. Um, Again, as a caregiver, I get it. I've shared publicly. I thought I was doing really well and had a breakdown at the doctor's office. And so we all we can, even us, if we're strong, right? Like we can have those moments.
Hmm.
Um, let's see. I think I saw something pop up in the comments. Thank you for sharing this topic. Not all hospices are bad. I had a positive experience in Florida with my sister on hospice. They treated her like family. That is wonderful. We love hearing that. We love hearing that. And was there another? Thank you both and good rest of week to everyone. We will carry on. Yes, we will. I love that. So big hugs. I'm a hugger. So if you were right here, I would be hugging you. Raft, Sydney, thank you again. I love that you put your information. I will send a follow-up email. You're so welcome. Thank you for sharing space with us this evening live, or if you're watching this playback, please check out all that Raft has to offer, even though they're centralized to the Northern Virginia area, their resources can expand outside of that. And we like to have
Absolutely.
her on these groups so that
Always happy to join. Thank you all so much. And just, I see we have 5 minutes left. I just want to share one little thing about self-care that I've been doing, and I think it's been really helpful. You know, whether you're a caregiver or whatever you have going on, it's a stressful time. The news is stressful. I have been trying to just find even just little ways of joy and whimsy in my life as much as possible. And one of the things I just got, it's very silly, but I thought I'd share, is it suctions to the shower a little disco ball that when I can dance and have just a little bit of brightness
I
in a
love
very
it.
everyday thing.
I love that. Oh my goodness, how much I love that.
Yeah. I figured you would. It was $10, look it up. Just a little thing to just make life a little bit more fun when it's hard sometimes.
I love it. And that is a wonderful place to end.
Yeah.
Get your disco ball, guys.
All right.
All right. Well, you all have a wonderful evening once again. Thank you, Sydney. I don't know, I don't have in front of me what next month's topic will be, but I'll send that out. And take care of yourself, and we'll see you either in the groups or next month.
Take care, everyone. Bye.
Bye.